hypokalemia discussion. And so I think if you're familiar with, if you read it over, the treatment in the book is very good in light of what we talked about last time. Make sure you take a look at figure 730. It summarizes all of the different factors that can contribute to either hyperkalemia or hypokalemia. Figure 320 on page 65. It summarizes all of the factors that contribute to hypokalemia and hyperkalemia and how they do it. And we're going to spend the rest of the time today talking about acid-base pathophysiology. Did everybody have a chance to look at that website that I told you about to walk through some of those problems? Okay, well, at some point in time you'll have to. It might be that on the test is the first time you have to, which would be unfortunate. But all right, let's talk about acid base and. Okay, so the book starts out by making a couple of fundamental things that you need to be aware of. You know that if somebody has a pH that is greater than 7.4, then we say that they have alkalemia. If somebody has pH of less than 7.4, again, it's a range, usually 7.35 to 7.7, the normal pH. If it's below the normal range, it's going to be acid. Above that, it's going to be alkalemia. And presumably, there is a process that underlies the pH disturbance. So, if the patient is acidemic, there is an acidotic process that is causing the acidemia, maybe two processes. And if they're alkalemic, there is an alkalotic process or processes that's causing the alkalemia. If the patient has a primary metabolic disturbance, then it's the lungs that try and compensate for it. If the person has a primary respiratory disturbance, then it's the kidneys that try to compensate for it metabolically. The respiratory, the things that you're going to look at in analyzing an acid-base disturbance, besides the pH, we're going to include the PCO2, which is going to reflect the activity of, among other things, of the lungs, and the bicarbonate, which is going to reflect the activity of the kidneys in terms of trying to compensate. So let's talk about each of the different primary acid-base disturbances, and then we'll talk about the approach to the patient with an acid-base disturbance. Okay? So the first acid-base disturbance that they talk about is respiratory acidosis, and you can refer to figure 322 on page 67, panel A. And a respiratory acidosis is going to be recognized by an elevation of the PCO2 greater than normal. So if the normal PCO2 is, let's say, 40, if the PCO2 goes above that, or goes above the normal range, then that suggests that there's a respiratory acidosis, the process of respiratory acidosis. If that's the primary disturbance, if the patient has a primary respiratory acidosis, then what's going to happen is that the kidneys are going to try and compensate. And so what you'll see is a rise in the serum bicarbonate to try and compensate, to try and lower the pH, to try and raise the pH back towards normal. They have a respiratory acidosis. The kidneys are gonna hold on to bicarbonate in order to buffer the acidosis to try and raise the pH back towards normal. And so again, in figure 322, the hallmarks of a respiratory acidosis are a primary elevation in the CO2, a secondary or compensatory elevation of the bicarb, and a fall in the pH. Important thing to keep in mind is that with compensation, the body tries to bring the pH back to normal, but never succeeds in getting it back to normal completely. Compensation is towards normal, but never to normal. Okay? CO2. Okay? So that if you see, let's say somebody has an acidosis, and there was a rise in the bicarb, and now the pH is on the alkalic side of normal, you cannot attribute that to compensation or overcompensation. That doesn't happen. That means there's another process going on. Okay? And we'll talk about that later on. Some of the things that the differential diagnosis of respiratory acidosis is discussed on page 66. So, for example, patients that have COPD, obstructive lung disease, can be associated with respiratory acidosis. Or patients that are comatose or have a decrease in their respiratory rate, that can be associated with CO2 retention. Okay. Drug overdose, what have you. Or they mentioned also problems with the muscles of respiration or so anything that's going to interfere with the respiration can produce respiratory acidosis. Once you identify the process that you're seeing as respiratory acidosis, obviously the next step is to ask yourself, okay, why does this patient have a respiratory acidosis? What underlying process, the disease, is causing the respiratory acidosis? The second primary disturbance is respiratory alkalosis. Respiratory alkalosis is basically the opposite of respiratory acidosis. So these people have a primary fall in the PCO2. So if a normal PCO2, let's say, is 35 to 45, theirs is going to be below that normal range. Okay? Because the CO2 goes down, okay, the body is less acidotic, protons go down, and so what's going to happen is that the kidney is going to seek to excrete bicarbonate in order to restore the pH back towards normal. So these people are characterized by a drop in the CO2, primary drop in the CO2, a secondary drop in the bicarbonate, and a rise in the pH. So the entities that are associated with respiratory alkalosis are entities that are associated with hyperventilation. They give you a number of them there, including certain drugs can do it. Salicylates are classical for causing hyperventilation and causing a respiratory alkalosis in association with a metabolic acidosis, which we'll see later on. So that is the hallmark of salicylate toxicity. Patients that have pulmonary embolism and develop hypoxemia, they can develop hyperventilation and respiratory alkalosis as a result of that. And sepsis. Sepsis is also associated with a respiratory alkalosis. So you can suspect sepsis in a patient in the right clinical circumstances in a patient with an unexplained respiratory alkalosis. third primary primary acid-base disturbance is metabolic alkalosis. Panel C on figure 322. And the hallmark of that is that there's going to be a primary increase in the serum bicarbonate. So if the normal serum bicarbonate is going to be, let's say, 24, as the serum bicarbonate goes above that, they would say that that's associated with metabolic alkalosis. So that's suggestive of metabolic alkalosis. So they have, because of that, the pH goes up because of the fall, because of the rise in the bicarb. And so what happens is that the lungs, in an attempt to restore the pH back towards normal, they retain CO2 in order to buffer the increased base. So again, what you expect to see in these patients is a primary increase in the CO2, the PCO2, a secondary or compensatory increase in the bicarbonate, and the pH is going to be elevated. They give you a couple of different scenarios under which metabolic alkalosis can be seen, including acid-base shifts across cell membranes, vomiting, because when patients vomit, they are losing gastric juice, which is rich in protons, rich in H+ ions, and so if you're losing basically an acid fluid, what's going to be left behind is going to be basic. It's going to be base or alkaline. And then certain conditions that are associated with loss of bicarbonate, or rather with a gain of bicarbonate. The final primary acid-base disorder is metabolic alkalosis, acidosis rather, and this is probably the most interesting one. Metabolic acidosis is going to be characterized by a decrease in the serum bicarbonate with a consequent fall in the pH, and then the lungs attempt to buffer the acid-base disturbance by blowing off CO2, getting rid of CO2. So you'll recognize metabolic acidosis by a primary fall in the PCO2. A primary fall in the serum bicarbonate, a secondary or compensatory fall in the CO2, and then what's left behind is a fall in the pH, the indication of the acidemia is the acidosis. Okay, so just to recap, if you're dealing with a respiratory acid-base disturbance, the primary abnormality is with PCO2. And what happens with the bicarbonate, the HCO3, is compensatory. If you're dealing with a primary metabolic acid-base disturbance, then the primary disturbance is with the bicarbonate, and what happens with the CO2, the PCO2, is compensatory. Does everybody see that? All right. There are two types of metabolic acidosis that have to be distinguished from each other. Okay? There are the so-called anion gap metabolic acidoses, and there are the non-anion gap metabolic acidoses. All right? And the way you distinguish them is by measuring the anion gap, and the anion gap is calculated by adding the chloride and the bicarbonate on a base metabolic panel. So you get sodium, potassium, chloride, and bicarbonate. Okay, sodium, potassium, chloride, bicarbonate. Okay, so you're going to add these two together because they're both anions. Okay? And this is cation. Okay, you're going to subtract this sum from that. Okay? So it's the sodium minus the sodium minus the chloride plus the bicarbonate. And that, the answer, whatever you get, is equal to the anion gap. And it refers to the fact that there's a lot of the anionic charge. Obviously, we're electrically neutral, right? Otherwise, that would be a problem in the charge. So we're electrically neutral, but a lot of the anions, negative charges, are provided by things that we don't measure. Okay, and so that gap reflects that fact. Okay, and the normal anion gap is like 12 to 16 or so. What does the book tell you? Maybe it says 10 to 14 or something. We'll use what the book says. It's 12 plus or minus 2 plus or minus 4, something like that. Okay. So an anion gap acidosis is associated with an elevated anion gap. So let's say normal is 10 to 12 or 10 to 14. If it's above that range, then you'll be provided with the normal range for test purposes. If it's above that range, then we say it's an anion gap acidosis, anion gap metabolic acidosis. If the anion gap is normal, then we say it's a non-anion gap metabolic acidosis. Right? If it's a non-anion gap metabolic acidosis, another name for that is a hyperchloremic metabolic acidosis, because it means that most of the negative charges are being provided by the chloride. Everybody see that? Because the negative charges are provided by bicarbonate and chloride. But if it's an acidosis, by metabolic acidosis, by definition, this number has to be low. So what's making up for that? Well, if it's not an anion gap, and it's not coming from an unmeasured anion, it's got to be chloride. Everybody see that? So another name for a non-anion gap acidosis is a hypochloremic metabolic acidosis. Right? Let's talk about the differential diagnosis of each of these two conditions. You need to know the differential diagnosis of each of these two conditions. So the first one is anion gap acidosis. And the book has some mnemonics too. You can use the mnemonics in the book, but the way I remember it is that the things that can cause anion gap acidosis include renal failure, lactic acidosis, ketoacidosis. It's four things, okay? Lactic acidosis, ketoacidosis, renal failure, and then the fourth thing is ingestions. And there are four substances. That's how you remember. Four things and then four substances that can cause a metabolic acidosis that is of the anion gap type. Methanol, which you shouldn't be drinking, right? But some people do. Methanol, ethylene glycol, which is like antifreeze, formaldehyde, salicylate. Yeah, I think that's right. There's a mnemonic in here somewhere. Don't think
the mud pile?
Yeah, where is that?
Page 68 from the left-hand column, third paragraph from the top.
68?
Page 68, yes.
Left-hand column?
Left-hand column, third paragraph from the top. Mud pile. At the end of the paragraph.
Oh, I see it. Okay. Yeah, so that's right. So that's right. You can remember that, or you can remember the way I put it. Four things: lactic, keto, ingestions, and then renal failure. Remember that there's two different types of ketoacidosis. There's diabetic ketoacidosis, but there's also alcoholic ketoacidosis. Okay? Either one of those can produce an anion gap acidosis. Be aware of that. The second type of metabolic acidosis is the non-anion gap metabolic acidosis, or the hyperkalemic metabolic acidosis. And the way you remember that is the rule of two. Okay? So, there are two drugs that can cause it. And those two drugs are diamox, which is also known as acetazolamide, diamox or acetazolamide, and ammonium chloride, NH4Cl, ammonium chloride. There's two GI causes, diarrhea and ureterosigmoidostomy, which is where they hook the ureter up, they hook the bowel up, they hook the ureters up into the bowel to drain urine into the colon. They don't do that anymore. They use other ways to deal with somebody that doesn't have a bladder. But that was a way that was a procedure that would cause a non-anion gap acidosis. Ureterosigmoidostomy, and then basically diverting the ureters into the bowel. If you do that, you can develop this non-anion gap acidosis. And then there's two renal causes. So two GI causes, two renal causes, two drugs. The two renal causes are renal tubular acidosis and renal failure. So renal failure can cause both an anion gap acidosis and a non-anion gap acidosis. Okay, so now we're going to talk a little bit about the renal tubular acidoses. And there's three renal tubular acidoses: type 1, type 2, and type 4. There is no type 3. So type 1 renal tubular acidosis is referred to as the distal type. It's associated with an impairment of proton secretion in the distal nephron. And it's recognized by a urine pH greater than 5.5. Type 2 renal tubular acidosis, or proximal renal tubular acidosis, is a defect not in proton secretion but in bicarbonate reabsorption. And it's recognized by a urine pH of greater than 7. That's true if the bicarbonate is normal. Otherwise, supposedly the pH is low, less than 5.5. I think it's more important that you be able to recognize that somebody has a renal tubular acidosis rather than being able to memorize and remember, what's the hallmark of 1 and 2. You can always look that up. The thing is to recognize that somebody has a renal tubular acidosis, and then say, how do you distinguish these? Look it up, and then you can order the appropriate test. The fourth type of renal tubular acidosis is one that we've already referred to. It's type 4 renal tubular acidosis. You remember that that's hyporenin hypoaldo. So this is the genesis of type 4 renal tubular acidosis is hypoaldosteronism. You can see this, remember, in people who have, particularly people who have diabetes. Remember that? We talked about that. And we said that this is associated with the potassium abnormalities, right? This is their hypoaldosteronism. It's going to be sodium and potassium abnormalities. Okay, so if you look at page 69, they give you like this algorithm for acid-base disturbances, but you need to be aware of the fact that this algorithm is flawed because it's overly simplistic, because it does not recognize the fact that there are these things called mixed acid-base disorders. So not everybody has a simple respiratory acidosis or respiratory alkalosis or metabolic acidosis or metabolic alkalosis with compensation. Sometimes they have a secondary disturbance, okay, another primary disturbance. So you need to be aware of how to recognize those. Oh, yeah, actually, the last thing before we talk about those more complex disorders, if you look at the bottom of page 69, you have the approach to the patients with metabolic acidosis. If it's an anion gap, you know what the differential diagnosis is. I also tell you what the differential diagnosis is if it's a non-anion gap. And what they're saying at the bottom of page 69 is about how to use the urine anion gap, which is calculated the same way, except you use urine instead of plasma to calculate it. The urine anion gap to distinguish among the different causes of non-anion gap acidosis. And what the book says is if the urine anion gap is highly negative, then you can conclude that the problem is in the bowel, it's extrarenal, whereas if the urine anion gap is 0 or positive, then the disorder is in the kidneys. Since that's a little bit vague, I looked it up, and apparently the average urine anion gap is going to be around -20, -27, plus or minus -10. So it's anywhere from I guess -17 to -37. So if it's highly negative, then it suggests that you're dealing with an extrarenal problem. If it's positive or 0, then it suggests you're dealing with a problem that is in the kidneys themselves. All right. Now what we're going to do is we're going to take up before we do, by the way, does anybody have any questions about anything we talked about so far? Yeah.
I'm having trouble with the urine anion gap equation.
Yeah.
How do you figure out the math? What are you trying to figure out? What's -17 and -37?
Okay, so you plug the numbers in. You do a urine spot, sodium and chloride and bicarbonate. You get these numbers, send the urine to the lab, and you ask them to calculate these numbers, right? And then you plug the numbers in, okay? And the sodium minus this sum is going to give you the urine anion gap.
So the book formula is nothing to do with what you're saying, because they have the concentration of ammonia in the equation.
Well, but they're just okay. But it's they show that they're showing that on the other side of the equation, but you don't need that as part of the equation. They're showing that those two things should be equal.
So we shouldn't.
You don't need to worry about that. For the purposes no, you don't have to worry about it. You can understand that for pathophysiologic purposes that it's figuring in that's one of the ways that the kidneys is excreting protons in the form of ammonia. Okay, but what you should understand is you're going to plug these numbers in. All right. What's going to happen is that the number you get out is probably going to be most of the time in a normal person it's going to be negative. It's going to be anywhere from -17 to -37. Okay, because these numbers, this sum is going to be greater than the sodium. Okay, and yeah, it's going to be greater than sodium. So then, if the number that you calculate is 0 or positive, then that's going to tell you that you're dealing with a renal problem. If the number is negative, highly negative, as you expect, then the problem is outside of the kidney, not in the kidney. All right? Yeah.
We can ignore the potassium for these calculations.
So the anion gap? Yeah. That's what when I looked up, that's what it said. Yeah, for our purposes, if it's 0 or positive, conclude that it's in the problem is in the kidneys. Otherwise, you can say the problem is outside the kidneys. All right. Other questions about this? And again, the thing to recognize is that this is one way you can distinguish between if it's not clear, why the person has a non-anion gap acidosis. This may help you sort it out. Okay. All right. So let's talk about some cases which will illustrate an approach that you can use, and also will illustrate some of the complexity that the book leaves out. So let's talk first about how we're going to. I'll give you a roadmap so that you know how we're going to approach these cases and how you should approach it, and then we'll actually apply it to some problems. Okay. So the first question you're going to ask yourself in a series of questions. The first question you're going to ask yourself is the patient acidemic or alkalemic? And how are you going to answer that question? You're going to look at the pH. The answer is going to come from the pH. Okay? Second question. What is the minimum primary diagnosis? In other words, if the patient has an acidosis, if the patient has an acidemia, okay, then the minimum primary diagnosis has to be either a respiratory acidosis or a metabolic acidosis, right? It's got to have one or the other, right? Everybody see that? Okay. But sometimes the minimum primary diagnosis is going to be that there's more than one. Okay? One will not explain it. You'll see that in a little while. The third thing, you want to calculate the anion gap. Fourth, we haven't talked about this yet, but you're going to calculate something called the delta gap. Fifth, you're going to calculate the starting bicarbonate. This will all make sense in a little while. Sixth, you're going to assess or calculate compensation. Seventh, you're going to make a list of all of the acid-base disturbances that must be present. And then finally, you're going to clinically put it together, correlate it clinically with what's going on with the patient. Okay, so let's take the first case. A 99-year-old man is wheeled in from a nursing home in shock and hypothermia. You want to probably write these down so that you can work with them in front of you. Sodium is 143. Potassium is 3.9. Chloride is 98. Bicarbonate is 22. Glucose is 126. BUN is 9. And then that's from the basic metabolic panel, right? And then on the blood gas, his pH is 7.61, his PCO2 is 23, and his PO2 is 95. Yeah.
What did you say was 9 after the glucose?
UN.
Okay, thank you.
Okay, so we're going to go through this. The first step is you ask yourself, is the patient acidemic or alkalemic? Alkalemic. The pH is 7.61. Everybody's comfortable with that, right? So what is the minimum process that is producing this disturbance? Remember, we said it has to be either, if there's alkalemic, it has to be either a respiratory alkalemia or a metabolic, respiratory alkalosis or metabolic alkalosis. So which one are we dealing with here? Respiratory. And you know that because what? Because the PCO2 is lower than normal. PCO2 is 23, and it should be about 40. Okay? Look at the bicarbonate. The bicarbonate is near normal, right? 24 is, let's say, a normal bicarbonate. 22 might be within the range of, might be within error. Okay, it's a little bit on the low side, and so that might be a cause for concern. Okay, because why? What would we expect to see with the bicarbonate? We'd expect that if the kidneys are going to compensate for a respiratory alkalosis, right? We expect them. Hold on a second. We're dealing with a respiratory alkalosis. Hold on 1 second. Respiratory alkalosis. So PCO2 blowing off CO2 to the H is down. No, I'm sorry. So that's okay. So the bicarbonate is it's a little bit low, but it's within a couple of what's normal. So the minimum primary diagnosis is respiratory alkalosis. The third thing we do is we calculate the anion gap. What's the anion gap in this patient? Say it again. 23. 23. Okay, and a normal anion gap is going to be 12. Is that 12? So there's something called the delta gap. The delta anion gap, which is going to equal to the measured anion gap, which is 23, minus the normal anion gap, which is 12. So our delta gap is 11. The delta gap, or the delta anion gap, is the measured anion gap minus 12, minus the normal anion gap. So in this case, it's 23 minus 12, and that works out to 11. That was step 4. The fifth step is now you have to calculate the starting bicarb. So here's what's happening here. This hopefully will simplify this for a lot of people. What you're doing in this step is you're saying, okay, so there's an anion gap here. If I corrected the anion gap, if I got rid of the anion gap, would that solve this patient's problem? That's what you're asking yourself when you calculate the starting bicarbonate. So what you do is you take the delta gap, okay, and you add it to the bicarb that you measured in the blood. So in this case, the delta gap was 11. The measured bicarb is 22. So you add those two, and you get 33. Now, is a bicarbonate of 33 high, low, or normal? It's high. Okay, so what that tells you when you calculate the starting bicarb is that this patient, in addition to having a respiratory alkalosis, in addition to having a respiratory alkalosis, also has an underlying metabolic alkalosis. An underlying metabolic alkalosis. So in a patient that has a primary respiratory alkalosis with metabolic compensation, okay, a primary respiratory alkalosis with metabolic compensation, you would expect the serum bicarb to fall, right? The CO2 and the bicarb go in the same direction when you have a primary disturbance. Well, they went in the same direction this time, but the bicarb hardly moved at all. And the reason it hardly moves at all is because you have this other process, this other primary process, a metabolic alkalosis, which is pushing it back to the alkalotic side, alkalemic side. There are actually compensation formulas, I think you have compensation formulas in the material I directed you to. Remember seeing those compensation formulas? Yeah, the website? Remember seeing those compensation formulas? Okay, so if you're dealing with a respiratory alkalosis, okay, you should be able to predict what the expected bicarbonate is. Okay? You can predict what the bicarbonate is for a respiratory alkalosis. And you need to distinguish between whether the respiratory alkalosis is acute or whether the respiratory alkalosis is chronic. Okay? So somebody that has an acute respiratory alkalosis, okay, so they've just developed a respiratory alkalosis, okay? That person, their kidneys haven't had time to adjust yet. So the only buffering that they're going to do is intracellular buffering, okay? Protons crossing cell membrane, okay? Patients that have had it for like 48 hours, 72 hours, now the kidneys have had time to adjust and to kick in, and now they can start decreasing their reabsorption of bicarbonate. And so the difference between the compensation for an acute respiratory alkalosis and a chronic respiratory alkalosis is significant, okay? If somebody has an acute respiratory alkalosis, and this is in the materials, the University of Connecticut materials, the serum bicarbonate is going to decrease 2 milliequivalents per liter for every 10 millimeter mercury change in the PCO2. So this PCO2 has gone down, what? Let's say 20 or 20. So we'd expect the serum if it was acute, we'd expect the serum bicarbonate to go down, let's say 4. So we might expect it to go from 24 to 20 if it was acute. Okay? That would be compensation. Remember, this person has 22, right? We're measuring 22. If it's chronic, the drop in the bicarb is 4 for every 10 millimeter mercury change in the PCO2. So we would expect 8. You'd expect it to 24, 8, 16. You'd expect a serum bicarb of either 20 or 16. Somewhere between 20 and 16, whether this is acute and this is chronic. Okay? Is that right? Yeah. Yeah. But it doesn't fall in this range. It doesn't fall in that range, which tells you that compensation is not appropriate. And the reason compensation isn't appropriate is because there's this other process going on, this primary metabolic alkalosis, which you already knew because you calculated the starting bicarb, and the starting bicarb, before any of this happened, you know, the starting bicarb was 33, which means that there had to be metabolic alkalosis. Everybody see that? Yeah.
The blood calculation that means the serum bicarb and not the
No, use the serum bicarb. Yeah. All right. Any questions about this? Can you say it louder? I'm not hearing you. 8 is the expected fall if it's a chronic respiratory alkalosis. The patient has had it for a while. It means that the kidneys have now had a chance to kick in. And so this is the expected fall in the serum bicarbonate for the fall in the PCO2. This is the acute compensation. This is chronic compensation. And these are the numbers. When you subtract these numbers from this number, this is the number you get. Yeah.
Will you repeat that range? Acute.
Acute. Okay. Again, if you look at the compensation formulas, okay. When they talk about respiratory alkalosis, they give you two choices. They said it could be acute compensation or it could be chronic compensation. All right. So we don't know whether this patient's respiratory alkalosis is acute or chronic, but it's got to be one or the other, or it's got to be acute becoming chronic. It's got to be somewhere. It's either acute or chronic, or it's subacute somewhere in the middle. So it should fall somewhere in that range. If it doesn't fall in that range, okay, then that means that the compensation is not appropriate. Okay. So in this case, the problem is that the bicarbonate is not falling enough to even satisfy. You can't even say it's enough to satisfy acute compensation. Everybody see that? Do you understand what I'm saying? Does that make sense?
Yeah, I was just asking for like the number, but I can look that one.
The number. These numbers here? Like 20 and 16?
No, I understand how you got it.
I'm not sure what number you.
The fall of 2 milliequivalent.
Oh, okay, yeah.
Yeah.
It's in those materials there. Okay, so it's for acute, the bicarbonate falls 2 milliequivalents for every 10 millimeter change in the PCO2. And for chronic, it's 4 milliequivalents for every 10 millimeter change in the PCO2. Yeah. Starting bicarb. The bicarb is what you do is you add the 11 to the bicarb that was measured in the blood, which is 22. So 11 plus 22 is 33. You add the delta gap to the bicarb, the measured bicarb, and that gives you the starting bicarb. 24 is a normal bicarb. The normal bicarb. Normal bicarb.
Will each primary acidotic or alkalotic problem have its own rule for how much each will drop in?
Yes. If you look at it, and again, if you look at the materials, it gives you a table, compensatory responses for metabolic acidosis, metabolic alkalosis, and then respiratory. Each respiratory disturbance has two different possibilities: acute or chronic. Okay. The metabolics only have one possibility. Okay, so basically what we're dealing with here is we're dealing with a gentleman who has a, what do we have so far here? We have a couple of things going on. He has an alkalosis, okay? He's alkalemic. We know he's got a respiratory alkalosis. We know he's got we know he has a metabolic alkalosis as well. We know that based on the calculation of the starting bicarb, and we know that he's got an anion gap metabolic acidosis as well. And we know that because his anion gap is 23, right? Anion gap is elevated, so he's got to have an anion gap metabolic acidosis as well. So he has a couple of things going on. He's got a respiratory alkalosis, a metabolic alkalosis, and an anion gap metabolic acidosis. So this is one of those really complicated mixed acid-based disturbances that if you didn't have a structured approach to it, you didn't have an approach to it, you would not glean all that information. So what do you think's going on with this guy? So he's an old man from a nursing home. He's in shock, and his temperature is whatever, 95, 96, whatever.
Well, you said his D1 was 9.
D1 is 9.
That's pretty high, isn't it?
No.
Oh, that's normal.
Creatinine of 9 would be high. Say that again? Yeah, sepsis is a good thought. Remember, sepsis is associated with a respiratory alkalosis. Okay, and that would explain the respiratory alkalosis. What explains his anion gap metabolic acidosis?
Lactic acidosis?
What's that?
Lactic acidosis?
Okay, it could be lactic acidosis from hypotension. He's not perfusing. He's just building up lactic acidosis. And the other possibility, think about it, could be DKA, diabetic ketoacidosis. Probably not alcohol with ketoacidosis if he's coming from the nursing home. It could be DKA. It could be lactic acidosis. It's not renal failure, right? D1 is only 9. And then there's 4 ingestions: formaldehyde, methanol, ethylene glycol, and salicylate. No. So you can eliminate that. DKA, usually you don't see DKA. You don't have to have extremely high numbers, but usually they have to be at least 250 before you would think about DKA. All right? So this isn't DKA, but you should go through the differential diagnosis. Okay, look at that, or sugar's okay. All right? So sepsis so far sounds good with lactic acidosis. And what about the metabolic alkalosis? Why do you get metabolic alkalosis? One of the common causes of metabolic alkalosis is the so-called contraction alkalosis. So if your volume depleted, that's often associated with metabolic alkalosis and contraction alkalosis. So this could be, an elderly patient who is dehydrated, dry, and now he's developed, let's say, either pneumonia or a urinary tract infection, and he comes in with sepsis and hypotension and all those things. Questions about that first page or the approach? Do you have a question? Yeah, go ahead.
What was the significance of the patient's CO2 falling above the range of the compensation calculation? So his CO2 is 22, but the numbers we got on the board are 20 and 16. So
yeah, so that means he's not compensating appropriately. He's outside of that range. If the CO2, so we expect it to be between 20 and 16. If it falls on that side of the range, then you say it's suggestive of some type of an alkali process. Okay, that's interfering with the compensation. And if it falls on this side of the range, then you would say, well, maybe there's some kind of acidotic process that's keeping it from being inside of that range. I'll do another one. Okay, you know what? Let's take a few minutes. Take 5-10 minutes, and then we'll come back and we'll do some more.